My name is Michael Battelle, and I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with MASLD and MASH by advocating for access to approved treatments and care. Our very special guest today is Dr. Jorn Schattenberg, an internationally recognized hepatologist and professor of medicine in Hamburg, Germany. In part five of our 10-part Liver Insights 2 series, we're going to be speaking about an incredibly important topic, and that is your lab results and making sense of blood work and liver scans. Patients frequently receive tests without fully understanding them. Dr. Schonberg, could you please shed some light and provide guidance on how to interpret these results and how they relate to liver health?
Yes, Michael, and thanks for having me. Thanks for inviting me. It's a pleasure to be here tonight. And you're raising a great question because it's one that, as a physician that deals with liver disease, I'm trying to discuss and empower my patients on each time he comes to see me in clinics. There's a number of different situations here. I think some patients are primarily being referred for their abnormal liver enzymes, and liver enzymes, that's a test most doctors would get when they order a liver panel to check on the status of the liver and see if anything is going on in the liver. So those are called ALT and AST. Sometimes the GGT, a little bit more done in Europe. And there's a number of other tests, but these markers reflect how much stress there is in the liver. So I get some patients being referred with those markers, and before they're seeing me, they go on the internet and try to figure out, is that a lot of liver enzymes that is causing the referral here or not? And I think these patients come in with a certain question about liver disease. And those markers, ALT and AST, I try to view them as activity markers, right? How much is going on in the liver? I do additional tests, and I'm asking the question, what's the underlying liver disease? In many of my patients, this is metabolic liver disease. So there's a number of blood tests we're going to do to check on the metabolism, the diabetes, the lipids, and so on. They're not directly liver related, but they're more about the general metabolic health. And I think the second very important set of liver markers, I'd like to call them, are then the markers that look at the fibrosis stage, right? How many scarring has been there in the liver? And between the activity marker, what's going on right now, and the scarring markers, the fibrosis markers, what had happened, and the amount of injury over time, how much fibrosis has built up in my liver. I think those are the two important aspects you want to consider when talking about metabolic liver disease. I'm going to pause here for a second, and I know you might have a question to allow your viewers or our viewers to come back in, and then I'm happy to expand a little bit.
Well, the first thing is, what happens if, patients are going for their annual exam, let's say, or regular blood test that they have, and they don't see AST on there? Because I know sometimes it's not always something that's tested. So what about that?
That's absolutely right. So there's no standard as which liver enzymes or which blood tests overall should be within a blood exam. Sometimes it's a little bit depending on the medical system you're in, and we're talking about Canada. So, for example, as you highlighted, there's no AST included in there, but there could be an ALT. Now, those go in parallel, and they're important for a number of tests we do like to run as hepatologists to predict the risk of a patient. This could, for example, be the FIB-4 test. We might be talking about that in a little bit. But if there's a liver test done, I think it's important to understand its value. And as I said, the activity marker, the ALT, tells you what's going on in that specific moment where the blood test has been taken.
Okay. So let's say they get that AST and ALT test done, and then maybe you'll talk a little bit now about what that FIB-4 is, because you mentioned that before.
Yeah. So the FIB-4 is a test that indirectly assesses the amount of scarring or fibrosis in the liver. And that test is combining those two liver enzymes, ALT, AST, we talked about them previously, and then the blood platelets. And they're typically in a full blood count. So it's a different tube of blood. So if you want to have a FIB-4, it means your physician or the phlebotomist must have already taken two different tubes of blood. In that in that FIB4. In addition to those 3 blood tests, platelets, AST, ALT, age is calculated. And I don't like to call it a diagnostic test, but it's an enrichment tool, or it's a risk prediction test. So it tells you about the likelihood of having advanced liver disease. And that's very useful because many patients with advanced liver disease are not being seen by liver physicians primarily, but by a physician that takes care of their diabetes, or the primary care physician. And they need some sort of filter in deciding which patients are at risk. And that FIB4 is perfectly set up to answer that, with a higher cutoff having a good chance of having advanced liver disease, and a lower cutoff with a very good chance of ruling out advanced liver disease.
Okay. So let's continue along the line and talk about other blood biomarker tests. In Canada, right now, there is the ELF that's available. You have to pay for it, but it is something that's available. And I'll let you go from there just to talk about that side of it before we get into the other diagnostics, if that's okay.
Yeah, that's a very interesting and novel marker, and it continues the discussion where we just left it. It's one of those markers that measures the amount of fibrosis by looking at fibrosis components of the fibrosis directly in the blood. So the FIB4 was an indirect test, and it looked at results of liver scarring. But the direct fibrosis markers, for example, the ELF, are part of the scar tissue that's being built up, and you can actually measure that in the blood. So it has a higher sensitivity to actually detect that fibrosis is there. And in addition, it has been used so extensively that we already can use it as a predictive biomarker. So it's not only diagnostic, it tells you whether the fibrosis is there or not. It also risk stratifies the patient groups into a group with a high risk of developing a liver problem in the near future.
Okay. And now in the US, there's also I don't know, want to keep naming all the name brands, but there are other tests. Maybe do you want to mention some of the other ones that are available?
Sure. So another interesting test that's been developed mostly out of clinical trials is, for example, the NIS4 test. It's really recently been found to NIS2 because that test combines activity and fibrosis. So all of a sudden, we're looking in a single blood biomarker in patients that have activity and fibrosis. And those are the ones we really want to treat. And for that, I do like those type of combination tests. It's not so commonly used, comes out of the research, but I think it's in general possible to do that. Talking about more fibrosis markers, there's a number of fibrosis markers that are being developed. For example, a procollagen fragment ProC3, and that can also be put into a score, the so-called ADAPT score. So a number of these direct scores are under development to actually identify the patients with more advanced liver disease. And remember, again, fibrosis is the amount of injury that has built up over time. So the question that the fibrosis marker is going to answer is how much fibrosis is in my liver right now that has occurred over time.
Okay, so you've talked about really in the real world, not necessarily in clinical studies, where people are going to very often have the ALT, AST, plus they're going to do FIB4, and probably that's a majority of what's going to be done on a day-to-day basis, right? And then plus there's the options to pay for some of the other more advanced ones if people wanted to, I guess, as well. So now let's go into some of the scans, those
Yes.
things are available, and that's a really big area as well. So.
Absolutely. So the big difference is here we've been talking about blood-based biomarkers, and they're particularly useful in the medical system because when blood is drawn, you can identify them on top. However, the liver is very susceptible to imaging modalities, both ultrasound or MR imaging mostly. Ultrasound's been available for the longest time, and it can give you some information on the structure. Ultrasound has since then been refined to actually allow for elastographic analyses, and those are ultrasound waves as well, but they actually quantify the amount of fibrosis and scar tissue in the liver, for example, in a test that's called VCTE, or transient elastography, and it's produced and sold on a machine that's called FibroScan. There's a number of different elastography technologies, also on other ultrasound machines, and there's different ultrasound makers. I think they do the same thing, but the one test that has been most extensively Validated also in clinical trials here for liver disease is clearly the FibroScan test today, and it uses the ultrasound wave properties in the liver to detect the amount of scarring. In addition, it also looks at the amount of fat. So it has two very important informations that are characteristic of metabolic liver disease, namely the amount of fat and how much scar is there.
I don't know if you want to comment or not. I mean, in the light of being transparent, there's Escopic and Mindray and other. So, is there big differences between them, in your opinion?
Oh, so that's a very good question. I would say the biggest difference is the time they've been in the field and the amount of data that's been generated. So clearly with the FibroScan, most data has been generated. But I totally align with you. There's a number of other imaging modalities. You mentioned Escopics that do directly assess liver tissue and allow for fibrosis and steatosis assessment with a little bit of, oh,
Bless you.
I have to start over. Thank you. That was coming. I thought I could sneeze it off, but anyways. So you're absolutely right in highlighting that there's a number of ultrasound-based technologies, for example, Escopics, that are able to also detect the amount of fat in the liver and are currently being validated in clinical trials. So if one test is not available, I think it's perfectly fine to go with the other test. It's important to remember that comparing between tests, that's probably not the best way. If you have a test done previously and then another test done, it's a little difficult to compare the numbers. But I think those tests work in a way where you're in a category of being in advanced disease stage, for example, or a lot of fat in your liver. And in these areas, they are well comparable. Another big area, and we're mostly seeing that in clinical trials, of course, MR imaging. That's a test that has the highest resolution and the highest amount of data that's been generated. Within clinical trials, we use tests to detect the amount of steatosis in the liver through MRI-PDFF, but also some stiffness measures, which are reflective of fibrosis, the so-called MRE tests.
And I actually had, as part of my education, I've tried pretty much all of the scans already. And I had also the MRI that was the Prospectum Liver Multiscan. And so obviously those are not available everywhere. And I think they've been involved in a lot of clinical trials as well. So is that something you think that patients might at some point have an access to as well?
Yeah, I think so. I mean, MR machines are available, particularly in Northern America and Canada, and you will have access to these tests. As a matter of fact, I think I would like to have an MR of my liver if I'm in question myself, because again, it has the highest resolution of all of these technologies. And in addition to looking at the amount of fat or liver, you could even combine that, for example, with scanning for hepatocellular carcinoma, which is another important aspect and realm of imaging that could be done by ultrasound, could be done by MR imaging, and patients with advanced liver disease based on MASH are recommended to undergo screening for cancer of the liver. So this could even be combined. Clearly, those tests are more expensive at this time, but there is a way to have access, even outside of clinical trials.
Now, you also said something really I want to follow up back on, and that was the serial nature of seeing progress. Maybe patients are already on treatment for MASH, as an example, or maybe they're not, and they're just they were told that they have fatty liver disease, steatosis, and they want to see how things are going. So ideally, they want to be on the same type of machine. So it was funny because I actually did the FibroScan and it was quite high. I started at 319. I know I talked to you about that a couple of years ago, and then I did the MRI and it came out between 1% and 4%. So I rechecked again the FibroScan and it was actually 187. So the numbers aren't going to relate, but I think the estimates about the amount of body fat available in the liver or present in the liver are something that can be examined over time as well.
Yeah, so there's a number of important comments, and we've touched on one. You cannot directly compare the numbers between the different tests based on the different physics behind those technologies, and then the vendors or the producers of the test convert it into something with algorithms. So it's difficult to compare them. But they put you in category or buckets, and that's well comparable. Now, the other important thing you said is, what does a test mean that changes over time? And that question is much more. We would assume, this is very logical, and each test must tell me whether I respond to a drug or not. But truly, these tests have mostly been developed to be diagnostic, meaning looking at one time point. And serial measurements of them are currently been done, and these exams need to be validated in order to be accepted as markers are able to predict treatment response, for example. We well know that, for example, the FibroScan, I'm going back to that test because there's a lot of data has been published on it. The change over a certain threshold, the 10 kilopascal threshold, if you stay above that threshold, you're much more likely to develop outcomes and endpoints that are bad for the liver, transplantation or decompensation. Whereas when you were high and you went below the 10 kilopascal cutoff, you are much better off, and your chance of developing these endpoints is significantly lower. So this is how some of these tests can be used and compare them over time. Not all of them, we have all the data and the granularity yet, but I'm very certain, with all the clinical research that's going on and the trials, we'll have more biomarkers. And in clinical practice, physicians use these tests as markers to predict response. The comments I'm making here is mostly related to strict regulations by the authorities, where you cannot assume that a test that drops a certain amount of numbers necessarily means that the patient has a real benefit.
Okay. And this discussion would not be complete if we didn't talk about what people don't want to have anymore, and that's a biopsy. So I just thought I'd throw that in there at the end to say, I know that there's a movement away from the need to do an invasive procedure like that. So what are your thoughts about that?
Yeah, I'm going to rephrase that a little bit, because I say that liver biopsy is a very important and useful test. I would not use liver biopsy these days to determine how much fat is in the liver. We talked about ultrasound, CAP. You mentioned escopics and other good tests that are very well capable of detecting the amount of fat, the MRI. I do not necessarily need a biopsy to say how much fibrosis is in the liver. We talked about the fibrosis tests. It's a little bit more tricky if I want to know the amount of inflammation, but I probably wouldn't do a biopsy to know how much inflammation is there. I'd use some markers and get closer. But biopsy is important if I want to know what liver disease is underlying. And there's a number of other liver diseases beyond metabolic liver disease. In that context, if it's unclear which liver disease is placed, autoimmune hepatitis, for example, a very important differentiator in some patients, particularly women, where I still might consider liver biopsy. But you're absolutely right that liver biopsy has lost its realm in many of those diagnostics aspects, because the biomarkers have just become so strong.
Thank you for today. I think we put a lot of information in a little bit of time, but for people that want to learn more about what those tests are that they keep getting and seeing from the doctors, at least now they have a background on where to go. And I know online, fattyliver.ca, our website, and other websites are out there if they want to explore a little bit more about each of those tests, right?
Absolutely. Thanks. It was a pleasure, Michael. Thanks for
Yeah.
having me, and sending greetings to everyone out there in Canada and the world.
Thank you.